Welcome to the MRCPology channel for a quick review and understanding of the topic. Imagine a child with infantile spasms, pale leaf-shaped patches on the skin, and an echocardiogram showing cardiac rhabdomyomas. For MRCP, that combination should immediately make you think of tuberous sclerosis complex. Tuberous sclerosis complex is an autosomal dominant hamartoma syndrome caused by loss of function in TSC1 or TSC2. A hamartoma means normal tissue cells growing in a disorganized way. The key mechanism is loss of inhibition of mTOR1, leading to abnormal cell growth, abnormal migration, and benign tumor formation in multiple organs. Most cases are de novo, so a negative family history does not exclude it. TSC2 disease is usually more severe than TSC1 disease, and this is a useful exam association. To understand the pathophysiology, think of TSC1 and TSC2 as a braking system. TSC1 makes hamartin, TSC2 makes tuberin. Hamartin and tuberin form a complex that normally inhibits Rheb. When Rheb is inhibited, mTOR1 is controlled and cell growth remains regulated. In tuberous sclerosis, mutation in TSC1 or TSC2 produces a defective hamartin-tuberin complex. The brake is lost. Rheb remains active. mTOR1 becomes overactive. This causes increased protein synthesis, increased cell growth, and abnormal proliferation. The result is hamartoma formation in the brain, skin, kidneys, heart, lungs, and retina. Now link the mechanism to the organs. In the brain, patients develop cortical tubers, subependymal nodules, and subependymal giant cell astrocytomas. In the skin, they develop facial angiofibromas, ash leaf macules, shagreen patches, and periungual fibromas. In the kidney, angiomyolipomas and cysts are common. In the heart, rhabdomyomas may be seen, especially antenatally or in neonates. In the lung, lymphangioliomyomatosis can occur, especially in females. In the retina, hamartomas may be seen. The brain manifestations are especially important for exams. During brain development, overactive mTOR disrupts neuronal and glial growth and migration. Abnormal migration leads to a disorganized cortex, producing cortical tubers. These tubers contain abnormal neuronal circuits, so they become epileptogenic. That is why seizures and infantile spasms are so characteristic. Abnormal cortical development also explains developmental delay, learning disability, and autism features. Clinically, the central nervous system features include seizures, infantile spasms, autism, intellectual disability, cortical tubers, subependymal nodules, and subependymal giant cell astrocytomas. A subependymal giant cell astrocytoma near the foramen of Monro is dangerous because it can obstruct cerebrospinal fluid flow and cause obstructive hydrocephalus. The key clue is a patient with tuberous sclerosis who develops headache, vomiting, papilloedema, or worsening neurological symptoms. The skin signs are high yield because they may give the diagnosis at the bedside. Hypomelanotic ash leaf macules are pale, leaf-shaped lesions. Facial angiofibromas are classically seen over the cheeks and nose. Shagreen patches are thickened, leathery plaques, often over the lower back. Periungual fibromas occur around the nails. Renal disease is a major cause of morbidity. Angiomyolipomas can bleed, cysts can contribute to renal impairment, and patients may develop hypertension and chronic kidney disease. MRCP trap. Do not think of tuberous sclerosis as only a neurological or dermatological disease. The renal complications are clinically important and need surveillance. Cardiac rhabdomyomas are often detected antenatally or in the neonatal period. They may regress with age, partly because mTOR signaling falls postnatally. Lung involvement is lymphangioliomyomatosis, mainly in females, causing cystic lung disease. Patients may present with dyspnea or pneumothorax. Diagnosis can be made clinically using major and minor features, but molecular diagnosis is by identifying a pathogenic TSC1 or TSC2 variant. Another MRCP trap, absence of a detectable variant, does not exclude tuberous sclerosis, because mosaicism or technical limitations may mean the mutation is not found on standard testing. Treatment is increasingly mechanism-based. Because the problem is overactive mTORC1, mTOR inhibitors such as everolimus and sirolimus can shrink subependymal giant cell astrocytomas, renal angiomyolipomas, and some skin or lung lesions. Seizures need anti-seizure treatment, and vigabatrin is first line for infantile spasms in tuberous sclerosis. Management is not a one-off intervention. Surveillance is lifelong. Children need brain imaging, especially to monitor for subependymal giant cell astrocytoma. Renal MRI is needed to assess angiomyolipomas and cysts. Blood pressure and estimated glomerular filtration rate should be monitored. Developmental review, skin assessment, eye assessment, and lung screening in adult females are also important. If you remember one thing, remember this. Tuberous sclerosis is loss of the hamartin-tuberin brake, causing Rheb activation, mTOR1 overactivity, and hamartomas across multiple organs. Quick recall. A child has infantile spasms, ash leaf macules, and cortical tubers on brain imaging. Which anti-seizure drug is first line for the spasms, and what is the underlying pathway abnormality? The answer is vigabatrin, and the underlying abnormality is loss of TSC1 or TSC2 function causing mTOR1 overactivation. A young woman with tuberous sclerosis develops dyspnea and recurrent pneumothorax, while renal imaging shows angiofibromas. What two organ complications are being suggested, and which mechanism-based drug class may help shrink some lesions? The answer is lymphangioliomyomatosis in the lung and angiomyolipomas in the kidney. And the mechanism-based treatment is an mTOR inhibitor, such as sirolimus or everolimus. Do subscribe to the channel for further videos.